Okay, well, thank you very much. It is a great pleasure to be here. It's an honor to be asked to speak to the All English Society. I want to thank Kumar for asking me to present. In the slides here, which should come up now, okay. So you see here my choice of intracameral antibiotic, and while you watch that video as I hydrate the side port and then inject the diluted intracameral Vigamox so that I can use the extra fluid to position the lens and make sure everything is stable, I'll tell you that I was asked to give another talk on the same topic more or less tomorrow, which I hope you'll attend. So I changed them both so they won't be the same. And I'm going to talk about the background and story of antibiotics today, and tomorrow I'll talk about some newer things. So the other session is marked over here. My disclosures are here. The only ones that are relevant are that NTOD sponsored my trip. So my real disclosures are I really like bilateral cataract surgery. 8/10 of my cases are bilateral cataracts, and I like using diluted intracameral Vigamox. I was the first in the world to use Vigamox intracamerally, and I noted that moxifloxacin is now probably the most common ophthalmic drug used in India. So I guess it's caught on quite well. So if we back up and we look at intracameral agents, we see that the first one to suggest using anything intracamerally as antibiotics was Jim Gills. And Jim Gills used it in the bottle, and he was a good friend of Howard Gimbel, who was a Canadian. And Gimbel encouraged Gills to change to go to use it at the end of the case as an intracameral injection. And they began to use intracameral gentamicin and vancomycin in about 1990 or 1991. And then gentamicin fell by the wayside because of its toxicity, and vancomycin became the drug that everybody used. And the question was, why did they choose vancomycin? Vancomycin is a very unusual drug. It was given its name because it was thought when it was discovered that it would vanquish all infections. It's a unique antibiotic. It's made by the soil bacterium Amycolotopsis orientalis, which was found in the jungles of Borneo in 1953. It's made by non-ribosomal protein synthesis, which means it's made in the cytoplasm, and all 7 amino acids in vancomycin are not found in proteins. So it's a very unusual drug, which makes you wonder maybe that's why we're seeing allergic responses to it, or allergic type responses to it. I used intracameral vancomycin for 10 years and had no complications. The paper from Axler Siegler, which said it caused CME, was refuted by many people and isn't really true. There was no resistance report to this drug for 40 years. It's the only drug ever sold that had that. And now we try to protect it as our drug of last resort. The next issue that came up in about 2000, when everyone said that if we use this drug, because a lot of us in ophthalmology were now using it intracamerally, if we use it, we're going to kill the world by getting resistant strains. So a few of us started to do calculations about how much we actually use and what the risk is. And it turns out I have a degree in microbiology. This all isn't just made up. It's some background to it. The amount that we use in ophthalmology is 30,000 times less than what they use in medicine. And they use even more in veterinary medicine. And then ophthalmologists were using just tiny bits of each bottle that we opened. And so really we're using 0.0003% of what medicine uses. But then when we use it in an eye, what we do with antibiotics is we don't create resistance, we select resistant strains. So you have to have a lot of exposure to a lot of bacteria to select resistant strains. So the exposure that you get in ophthalmology is about 1/10,000,000th of what you get when you take one pill of vancomycin for your C. difficile. And so if you calculate out the relative risk we have of how much we actually buy, how much we use, and the relative risk per dose, the risk is that when we give an intracameral injection, we would have to inject 10 billion eyes, every single person's eye in the world, in order to have the same risk of one patient taking one pill of vancomycin for C. difficile. So after we did this, a few years later, the Medical Letter, which is an American thing that talks about risks of drugs, came out and said that the use of these things in ophthalmology is really not significant, and we don't cause any problems. So the next problem was, well, how do we choose the dose we use? Well, we all look at the ESCRS study, and we think that they did a great job choosing a dose for ceftriaxone, for example. It turns out the ESCRS just took their stuff from Montan, and the entire ESCRS study was only a copy of this Swedish study done 5 years before. And when you read Montan's paper, what they said was they got the doses from Gimbel and Gills. So everyone just gets what the last guy used, and no one really figured out what the best choice is. So the Montan paper was done by these people you see here pictured, and there were 2 publications in 2002 which showed they could reduce the infection rates in Sweden probably from 1 in 500 down to 1 in about 1,600. And so the ESCRS thought this was a good drug, cefuroxime, to use to try to get a safe drug. So in 2006, the ESCRS came out with the results of their study, and since then we've all been using intracameral drugs of one sort or another. The study actually raised a lot of questions, aside from it showing us conclusively that intracameral antibiotics do reduce infection rates by a factor of about 8. So what we knew at the end of the ESCRS study is we knew that we have some numbers of things that actually do help us to prevent infections. We can use preoperative betaine. The Swedes use chlorhexidine, but in low concentration, not the stuff you get for skin. And that reduces infection rates. Tight wound closure reduces infection rates. Intracameral antibiotics do so significantly. But then many people use pre- and post-op antibiotics, and the thing is, that has never been shown to be effective or to have any difference. So there was an interesting study done by a guy named Lin Xiong-Tone in Saskatchewan, and he contradicted the work that was first done by Maskett to encourage everyone to use preoperative topical antibiotics. And what Lindsay showed, that if you look at the levels of antibiotic you achieve in the eye, they're not significantly bactericidal until you give it 3 times immediately prior to surgery, which means why give it 3 days before? And in terms of microbiology, when we give these drugs for 3 days before, what you're doing is you're killing off all the susceptible bacteria to the drug you're using, but you're allowing on a rich nutrient place now to grow the occasional resistant strain which might be wandering in the environment and to multiply for 3 days before the surgery. So in actuality, you're really increasing your risk of getting a resistant strain in the surgery instead of benefiting the patient. So there's a real question about why people want to use preoperative topical drugs, antibiotics. So then we did a large course with Per Montan and the group that were working on intracameral drugs at Lisbon. And one of the things he showed was that we calculated, a number of us have kept records of all the studies published, that there have been 24 studies supporting the fact that intracameral drugs really work very well, and 2 that showed that it didn't. But when we looked at the 2 that showed they didn't, they used suboptimal doses. So if you use a very low dose, of course you don't get a very good result. But other than that, in 6 million surgeries, every single study showed that you get a significant decrease in infections when using intracameral drugs. And so I have a list of a lot of them here, and I stopped at about 2 million. And what you can see is not only are they all effective, but you look at the numbers here of the infection rate with no intracameral drug and the infection rate here with intracameral cephalosporins. In every single case, the risk factor was that you reduce the risk by a factor of about 6 to 8. So it's not only that in a place where they had a high infection rate, like in Reus, Spain, of 1 in 160, they got a reduction, but also in Tehran, where they had a very, very low infection rate, it went down even more when they used intracameral drugs. So every single study that used an adequate dose shows that it works in many cases. So we did a study among all the bilateral cataract surgeons in the world, because we were accused we're going to blind the whole world, and we looked at what our infection rate was. Now, people don't do bilateral cataract surgery unless they're relatively confident and have low complication rates. So even without intracameral drugs, we had an infection rate of 1 in 2,000. With intracameral cefuroxime, it fell to 1 in 9,000, and with vancomycin and moxifloxacin, it fell even lower. And so it just shows you that even with the lowest reported infection rates in the world, you still reduce it by a factor of 8 or so when you use these drugs. So we were left with these 5 drugs, and then when we looked at all the drugs, you could drop out 2 of them because they were in the same class, same mechanism of action as a better drug in the same class. So now we have 3 drugs. We have vancomycin, cefuroxime, moxifloxacin. And we have to start comparing them to see which is the best one, because we know they work. So we know that time-dependent drugs in general are less effective because they rely on being there for a long time. And inside the eye, the concentration abates quite quickly. So if it's going down quickly, you have to look at the concentration 2 or 3 hours before to get a time-dependent drug to be effective. So vancomycin and cefuroxime are probably less effective than moxifloxacin, which is a dose-dependent drug, which means if you get a high enough dose, it essentially kills the bacteria right away. But we have to then look at the complications, because all of these drugs have some sort of issue to be concerned with. And we all know about vancomycin, which was the most popular intracameral drug in the United States, is now dropping in popularity ever since we found HORV. And even though HORV probably occurs only in an instance of 1 in a million, no one wants to have a patient who gets HORV, so vancomycin incident use is dropping off quickly. The problem with cefuroxime is the resistant strains. That when you get an infection with cefuroxime, you tend to grow enterococci, and the enterococci don't respond to the drugs that we normally use to treat endophthalmitis. So most of those infected patients go blind. So that's making cefuroxime be less and less popular as time goes on. It's also the drug in which, if you get dilution errors, you tend to get serious problems of TAS and fusarium and various complications in different countries. Moxifloxacin had remarkably few issues, except there's been this issue recently brought up, which is called BAIT. BAIT stands for bilateral acute iris translumination, because they're not sure if it's an iritis or just some toxicity to the pigment epithelium of the iris. So let's talk about that. This syndrome was first reported in this paper by the group of Janet Davis, and here's some pictures of some eyes, and it's found to occur in people who get systemic moxifloxacin in ICUs for a prolonged period of time. And some of them will get this syndrome, and they get severe, very high pressure, rapid onset of an iritis type picture, and loss of the pigment epithelium of their iris. And then this other Dr. Sandhu looked at a study of American huge databases and found that the patients that were getting this were patients that were already prone to getting iritis, like they had ankylosing spondylitis or something like that, and it wasn't a random sample of anybody. So it may not be a general risk. But Janet Davis responded and said, well, it seemed to her that people did not get this with topical drops, but got it with long-term systemic administration, was because the concentration achieved in the vitreous on the backside of the iris was much, much higher when you gave it orally than when you gave it topically. And so that was the hypothesis of why it was occurring. And then to make life exciting, because we'd never had a report of a case in giving it intracamerally, there was a report by Matthew Rund on the ASCRS Cataract Refractive Eye Connections Digest, and it occurred at approximately April 13th, 2016 at 8:22 p.m. when he posted it and everyone got excited. This is a case of a patient that got this syndrome, which you can see over here in one eye. They had been undergoing a vitrectomy for floaters, and they were given, in the anterior chamber, moxifloxacin intracamerally, and they got this. So I spoke to Matthew Rund. I tried to encourage him to publish that, and of course it wasn't his patient. So finally, in January of this year, the case was published in the Journal of Cataract and Refractive Surgery, and what happened was, it was indeed given in the anterior chamber, but probably the doctor who injected it under the iris because they were concerned that they'd done a vitrectomy and not a cataract surgery. And so when the iris is sitting on the lens, you could trap a high dose of intracameral moxifloxacin, and the dose you get intracamerally like that is essentially the same as the dose you get when you give it systemically for a prolonged period of time. So the current theory is that it's perfectly safe to use this when we do cataract surgery, because the iris is not left draped on the lens, but it's not safe to do it in a phakic patient. So that's where things stand with that. So now we have 3 antibiotics in the running. We have the reasons why we like or don't like them. Moxifloxacin is increasing all over the world in popularity. And moxifloxacin is fortunate in India that you have single-use preparations. You have Oromox from Aravind, but apparently it's only sold in Aravind, not everyone else gets it. But you have Forquin PFS sold by Ann Todd, which is the only preparation in the world of single-use injection of moxifloxacin in a syringe. So that's the story up to now, where we stand. And in my talk tomorrow, I'm going to go on to some new things and tell you how we can figure out abatement levels of drugs, which ones are probably better, and how we can choose how we administer the better. So thank you very much.